everybody, my name is Carly Bands and today I'll be presenting over Topic B. Topic B gives us Mr. L, a 40-year-old male who is presenting with shortness of breath, wheezing, and nighttime symptoms. He has a medical history of asthma that was diagnosed at 25 years old and allergic rhinitis. His vital signs are a temperature of 37.0 degrees Celsius, a heart rate of 98 beats per minute, a respiration rate of 22, a blood pressure of 128/82, and an oxygen saturation of 94% on room air. His physical exam shows audible wheezing, prolonged expiratory phase, and no cyanosis. So the most likely diagnosis for this patient would be exacerbation of asthma. Asthma is an obstructive disease reducing airflow, FEV1, and FEV1-FVC ratio. It is a chronic inflammatory disorder of bronchial mucosa, and it results from genetic susceptibility and environmental factors. So the anatomy and physiology of the respiratory system, your upper airway starts with your nose, your pharynx, and your larynx, and then you start to get into your lower respiratory tract, which is your trachea, bronchi, bronchioles, and alveoli. The goal of the pulmonary system is gas exchange, and we do that through ventilation and perfusion. But when we're specifically talking about the bronchioles and the bronchi, a healthy airway would look like a layer of epithelium that has goblet cells. These goblet cells secrete mucus, and then the cilia on top get rid of that mucus and anything that could be trapped in it, such as bacteria. Underneath our epithelial layer, we have a small basement membrane. Underneath that, we have a lamina propria with normal amounts of white blood cells and lymphocytes. Underneath that, we have a small smooth muscle layer, and then underneath that, we have an appropriate amount of submucosal glands. So the pathophysiology of asthma has two different phases. The first phase is the early phase. The early phase has two pathways. The first one shows an antigen that is connected to IgE that stimulates a mast cell. The mast cell will then degranulate and cause all of our inflammatory mediators to come to the site, such as histamine, interleukins, leukotrienes, and all of this just causes massive inflammation. Our second route of the early phase is the IgE antibody combined with the antigen. It is grabbed by a dendrite, which is an antigen presenting cell, and that dendrite presents it to a T helper cell, and then the T helper cell stimulates even more cytokine release. The specific cytokines that we're looking at here are interleukin-4, which stimulates the B cells to bring in even more IgE, interleukin-5, which stimulates an increase of eosinophils and neutrophils to the site, and interleukin-13, which causes an increase of mucus and airway damage. So that's our early phase, and then with our late phase, all these cytokines are starting to create epithelial damage and shedding. And what this does is just bring even more cytokines, eosinophils, T helper cells, leukocytes, all to the site of damage. I think a big key of this is that we also have a decrease of T regulatory cells. So all of these things are happening without any kind of regulation to stop them. Once we get so much exacerbation and inflammation and edema going on, we eventually have our sensory nerve activated, which causes the bronchoconstriction. So like we mentioned, asthma is a hypersensitivity and hyperresponsiveness. So that causes smooth muscle hypertrophy, increased vascularity, collagen deposits, and mucus plugs, which causes even more air trapping in those alveoli. The diagnostic findings that we have with this patient, just with his presenting symptoms, we have wheezing, shortness of breath, prolonged expiratory phase, and all of these are classic signs of asthma. We have to have a spirometry test to officially diagnose asthma. So we have an FEV1 of 78%, and remember FEV1 is the forced expiratory volume in 1 second. So 78% is low, so this patient has a little bit of obstruction going on. We also saw that this patient was given a bronchodilator, and his FEV1 after the bronchodilator improved by 12%, so that just further shows that we had some kind of obstruction going on. This patient was also given a methacholine challenge. Methacholine is a drug that causes bronchoconstriction, and his score of PC of 20 shows that he was very sensitive to the drug, which is showing that we have hyperresponsiveness, again, which is what asthma is, a hyperresponsiveness. This patient also had an allergy test that was positive for dust mites and pollen, and again, hyperresponsiveness, hypersensitivities, IgE antibodies, the things we've already discussed. Treatment for this patient would include education on allergens. He's a recreational athlete, so we would want to educate him on exercising or playing sports, possibly indoors, maybe where he could avoid outdoor pollen to decrease this hyper responsiveness. But medications for this patient would also include beta agonist bronchodilators, long-acting muscarinic antagonist, which also causes bronchodilation, leukotriene antagonist, which would decrease the inflammation. And I think this patient would also be a good candidate for immunotherapy. He has been using corticosteroids long-term, and the case states that his asthma is poorly controlled, so I think that would make him a good candidate for immunotherapy. Complications that this patient could see if he wasn't untreated would be status asthmaticus, which is a life-threatening bronchospasm that cannot be reversed by usual treatment. We see silent chest, which means there is no gas exchange, air movement going on in the lungs. And once we get to a PaCO2 greater than 70, we kind of have impending death that we're looking